Welcome all to this ongoing series. We are in the fourth session now. We are trying to touch upon antipsychotics. Now, I guess a lot of you would have already heard about antidepressants, mood stabilizers, some basics of psychopharmacology, all this in the previous sessions. We'll be talking about antipsychotics, the good, the bad, and the ugly aspects of it, the side effects, the effects, the kind of choices of medications we can go ahead and do. I'll try to keep it with three things in mind. One is I'm trying to bring in basic sciences and connect it to clinical work we do. Second is give you a lot of practical clinical challenges we go through, and possibly also how we address or how can we become better clinicians at the end of the day so that we could help the people in distress at large. This is the aim of the whole session. So we'll talk about some basics and neuroscience aspects. We'll talk about the clinical challenges and those things which come and the possible solutions we can look at. You're welcome to keep posting some questions which comes up in your head, and I'll try to answer once we are done at around 9 o'clock. And if there are some questions which you post in the page we have, I might be able to answer you back about your question specifically on the email. Okay, so with this, I want to start with a question here for you. The question is very simple, but I want you to think about and answer the question. Antipsychotics are not useful in OCD, dementia, bipolar disorder, or depression. Where do you think antipsychotics are not useful is the question. We will be talking about antipsychotics, but my question is, where is antipsychotics not useful? Is it in OCD? Is it in dementia? Is it in bipolar disorder? Or is it in depression? Shriram, can you put up 4 choices for people to answer? Please go ahead. As I waited more than 20-25 seconds, I see almost 50% have chosen not to answer this question. They are seeing this poll on their question, on the screen, but they choose not to answer. I guess one of the reason I'm seeing that nobody is wanting to answer this question is because you're wondering, what question is this? Antipsychotics are not useful in. Actually speaking, anybody who takes the definition of an antipsychotic is a medication which should be used against psychosis, is the definition. But we know that as clinicians, we do use antipsychotics in OCD, we do use antipsychotics in dementia patients, we do use antipsychotics in bipolar disorder patients, and we do use it in depression patients. But as a clinician, whenever we choose to use antipsychotics, the reason we use antipsychotics is different in each of this population. So even though it's the same agent, the reason we use is very different. Let me give an interesting point. I'm sure some of you, the clinicians, would have had similar experience. I had one of this patient of mine who booked up an appointment and came and met me, and he gave me some few pages of prescription, and he said, "Sir, I'm married last 1 year, and this is my wife's prescriptions. Can you see these prescriptions and say what is the diagnosis, or what is the illness, or what is the treatment?" First of all, I was curious to know why has he come by himself, and that too carrying prescription. And obviously, with little bit of knowledge, we know most of the times they're going through some marital issues. Sometimes they want to look for separation, or sometimes they want to understand the other person's mental health problems. So he might have come with his own good and bad reasons. When I saw the prescription, I saw the patient was on Risperidone 4 mg. Now, Risperidone 4 mg is the only medication this patient was taking, and it was the patient was taking it for almost like more than 6-9 months. Now, when I saw this a few years back, with my basic knowledge of psychiatry, I used to believe, okay, if it is Risperidone, basically the patient, if a doctor has given only Risperidone, mostly the patient is suffering from schizophrenia or some form of psychosis. That's it. That's what I would have thought about. But today, because my knowledge has improved, or maybe confusion has improved, I will not think of that process alone. I will definitely think it could be psychosis, but I might also think maybe there are other reasons why the doctor might have prescribed only an antipsychotic. So we'll be talking about how the whole class of antipsychotics are just not treatment for psychosis. They have their own complicated strategies, treatment, side effects, problems, and even indications and contraindications. So we'll be talking about the challenges with antipsychotics and how colorful this whole bunch of antipsychotics are. So before we understand about antipsychotics, let's try to understand some aspects of psychosis. What is psychotic symptom? Now, psychotic symptom is something which can happen in patients who are suffering from psychosis. We all know that, right? But we also need to understand, over years we have seen there is definitely a role of antipsychotic medications being used in behavioral problems, in OCD problems, in dementia, and definitely mood disorders. So when you're talking about psychotic symptoms, you need to understand there are some conditions in psychiatry where we define that condition or we diagnose that condition based on the presence of psychotic symptoms. Like, for example, if a patient has to be diagnosed with schizophrenia, he should have psychotic symptoms. Otherwise, you don't diagnose them with psychosis. A patient with delusional disorder should have delusions. Otherwise, you don't diagnose them with delusional disorder. A patient with mania with psychotic symptoms, a patient with severe depression with psychotic symptoms are little different. There, psychotic symptoms are not the prominent. They become associated conditions. Can you understand the difference now? Schizophrenia is an example of a defining condition where the psychosis which we see in the patient is the primary reason why we make the diagnosis. Whereas when you're talking about an associated condition, we are talking about conditions where psychosis can be seen, but it is not the primary requirement for you to make diagnosis. To give example, a defining condition example could be schizophrenia, delusional disorder, unspecified psychosis, and all those can be examples of defining conditions where psychosis is the core feature of your diagnosis. But what about associated features? When you're talking about associated conditions, you're talking about associated conditions like dementia patients. Now, dementia patients need not have psychosis, but we do see psychosis as a component in a lot of dementia patients. Delirium patients can have visual hallucinations, auditory hallucinations, and those. Manic patients, especially mania with psychotic symptoms and depression with psychotic symptoms, those kind of situations, you can see psychotic symptoms. Why am I stressing this point is because a lot of times when you prescribe, let's imagine I see a patient with schizophrenia and I diagnose the patient and put them on an antipsychotic. Now, you have to assume that your patient is going to go to Google and type the molecule or the brand name, whatever you've written, onto the Google search and see what the drug is for. Now, if I put an antipsychotic drug, if he reads about it, he's going to first of all question, what does he have? And again, you're dealing with psychosis, right? Psychosis patients basically many times might not even have insight. They might not even accept that they might have an illness. In that case, what do you think will happen? When they read about it, they might refuse to take the medications and those things. So it's a common problem today that if you don't basically explain the patient why you need to give the medication and tell the reason why you have prescribed the medication, they are going to read on the net and decide, okay, this is why the doctor might have decided. Like, the reverse happens in some patients. In depression patients, when I add a small dose of, let's imagine, aripiprazole as an augmenting agent, the patient goes and reads, why is this new molecule added? They read about aripiprazole, and the first few indications will be about schizophrenia. The patient is scared and doesn't want to come back to me. The reason is they believe the doctor is thinking I have schizophrenia. Actually, my reason of adding aripiprazole would have been just to augment. So it's important for you to understand that when you prescribe the patient, he is going to go and do a Google search. And it is good for you to give some information before he does wrong search and get confused and unfortunately not take medicine, which only hampers their quality of life. So if we tell them whether this is the diagnosis, this is the reason I'm giving this medication, at least briefly a few salient points, it helps them to become more compliant and understand. Now, lot of times as medical doctors and as well even basic professionals who are entering into psychiatry would think psychosis means delusions, hallucinations. When I've interacted with a lot of undergraduate students, I ask, okay, can you tell me some symptoms of psychosis? They'll say delusion, sir. If I give another 10 seconds, they'll say hallucinations. And there they stop. They don't think anything else can be psychotic presentations. But in routine practices, we know there are a lot other ways in which patients present. Disorganized symptoms. Now, disorganized symptoms can be in thoughts, disorganized symptoms can be in speech, disorganized symptoms can be in behavior. Catatonic symptoms. Catatonia is a part of psychosis, right? And negative symptoms is also an important point you need to understand. There are interesting highlights I would like to make here. When you see the kind of practice you see, you end up seeing some patients who present with very difficult diagnostic challenges. Like recently, I saw this young girl who's about 17 odd years who has not been going to school for about 4 years now, has refused to go to school and sitting at home. Now, 4 years, she hardly has gone out of the house about 5, 6 times. And that too, most of the times she's been forced to go to meet a mental health professional. She would meet once or twice and then stop going. Other than that, she hardly gets out of the house for any reason at all. So her lockdown is not from March of last year. Her lockdown has been going on for last 4 years now. Now, when I was speaking to her, my questions would be very simple, but our answers would be extremely elaborate, too many sentences, some new words getting added here and there. I would not understand why is she using this English word here, English word there. It would be a little jumbled up. And sometimes I had to question her, what does this mean? What is this new word? So it looked little jumbled up. That is when we thought, okay, this patient might be actually having disorganization of her speech and thought process. We used the help of a psychologist and tried to do Rorschach's test and object sorting test, in which we found a lot of psychotic processes happening. When we added a small dose of an antipsychotic, we saw the patient responding beautifully to these thought processes. The patient got very much in streamline, started taking care of herself. She started going for some computer classes and those. She did not present with delusions. She did not present with hallucinations, but this is how she presented. So psychosis not necessarily means delusions, hallucinations. You need to look for disorganized behaviors, disorganized thoughts, disorganized speech. You need to collect speech samples and look at them. And a lot of people today in this young world, they maintain social media posts, right? So sometimes they write blogs. If you ask them to share some samples of their blogs, you will see weird grammar. You would just not make sense what they've written. It would be some odd topics, elaborately written with no clear connections. So these also can become your speech samples, not just your clinical interview, but other things. So it's important for us to look at all these aspects when we are kind of diagnosing. If you don't diagnose well, forget about choosing the right molecule, because it doesn't matter, right? When you don't diagnose well, you cannot treat them well. So that's important. I want to highlight a specific point in relation to negative symptoms. Why? Because first of all, as doctors, we know when we are treating patients with psychiatric symptoms, especially psychotic symptoms, negative symptoms are little difficult to treat, right? Negative symptoms are difficult to respond to even medications, generally speaking. And what are the common negative symptoms? Apathy, evolution, amotivation, anhedonia, asociality, social withdrawal, logia, not talking much, affective flattening or affective blunting, attention deficit. All of those typically can happen as components of negative symptoms. Now, what I want to highlight to you, what is also the fact that if you see the kind of practice you do, most of the times patients, when they become aggressive, violent, or talking some unusual things or behaving odd, they're brought to you much early. But whereas patients with negative symptoms will be brought to you few months to few years in delay. Why? Because these patients are very withdrawn and silent, so they don't actually trouble anybody else. So they, family members think and wait, okay, this guy is maybe lazy, this guy is maybe kind of sad, maybe he's worried about his job. So they wait and wait and wait. In fact, you will see in your practice, many times patients who are aggressive, violent, and disturbed, somehow they kind of even involuntarily try to bring them by force or tell them a lie and bring them to the clinical space. But a person who's having a lot of negative symptoms is going to take a lot of time. What does that mean now? First of all, negative symptoms are difficult to treat for you. Moreover, if the patient has not come to you for a long time, he's been psychotic for a pretty long time. And you know that the later the starting of medication, the worse is the prognosis. So you want to treat much early and intervene much early. So when we actually educate the community at large, we should not only just talk about what is important in terms of aggression, violence, and the positive psychotic symptoms. It is also good to highlight that very unusual withdrawal and social isolation and kind of getting into a shell could be sometimes a symptom of psychosis, and it needs a mental health professional intervention as early as possible. So it's a good idea to sensitize the community at large. Typically, we all believe schizophrenia is an illness which has delusions, hallucinations, and those. And a lot of movies kind of dramatically show these patients with schizophrenia and all. In a routine practice, if you see, schizophrenia typically can have five important presentations and components. What are the five important presentations and components schizophrenia patients can be presenting with? One is the positive symptoms, which is delusions, hallucinations, thought phenomena, made phenomena, all of those stuff. You can see schizophrenia patients coming with a lot of negative symptoms again. Patients come with a lot of affective symptoms, mood symptoms, too much anger, too much sadness, sometimes extreme anxiety. All those kind of affective symptoms can happen. You can also see aggression, violence as one of the components which can happen. That's also one of the challenges, right? It is important for us to notice cognitive problems are very, very important. And as clinicians of the future, we also need to understand these are going to be even more challenging problems. Why? Because today a lot of population whom we see are working population, and these are people who are working in industries and software industry, technology. They are kind of dealing with high levels of cognitions and those. So basically, if they have even a 10-20% residual deficit which is left behind when we treat them, you need to understand they need a lot of rehabilitation process, cognitive remediation, and those things. Otherwise, they're going to struggle on their day-to-day practice. You want them to retain their jobs and go back to work. They would want to go, but they might not be able to perform at their earlier best. So it is important for us to identify cognitive problems, talk to a good neuropsychologist, assess for it at the earliest, try to do interventions, try to work with cognitive remediation and those things. So it becomes important as a clinician for us to not just look at delusions, hallucinations are the positive components or the aggressive components, because those are what will scream to you. The patient's behaviors will scream to you. He is violent, family members are concerned. He's talking some things which looks very crazy and the family members don't understand about it. They're going to come and tell you, do something about it. But the more dangerous things are the negative symptoms, the more dangerous things are the cognitive symptoms. And unfortunately, if you have read enough of antipsychotics, you know the medications work the least with negative symptoms and cognitive symptoms, which are going to be quite a challenge. So as clinicians, we need to understand we should look for these things and try to address it. So when you want to try to address it, first of all, we need to understand some basic aspects of different areas of the brain, right? Some of the important circuits you need to understand is, let me keep it very simple for you. The positive symptoms are basically linked with the mesolimbic system. The negative symptoms are typically linked with the mesocortical system, and not just the mesocortical system. It is also linked with the prefrontal cortex, nucleus accumbens area. So negative symptoms, nucleus accumbens, prefrontal cortex, mesocortical areas, whereas the positive symptoms are typically linked with the mesolimbic system, is what you can remember. Uh, Affective symptoms are more with the ventromedial prefrontal cortex area, whereas the aggressive symptoms are related to the orbitofrontal prefrontal cortex area. And of course, aggression, amygdala go hand in hand. That's important for us to know. So when you're talking about the cognitive symptoms, it is important for us to know that DLPFC, the dorsolateral prefrontal cortex, is an important area which is known to be linked with dysfunction with cognitive issues. Now, why should we have this idea about it? This is where a lot of modulation techniques and other things are coming up, right? Today we have RTMS and other modulation techniques which are coming up, and a lot of research happening to see whether stimulation or inhibition of a particular area can make a difference in these patients. And we know these are areas where pharmacology stops and other modulation techniques starts. So we need to look at these strategies to work for. So every patient with psychosis is just not about delusions, hallucinations, and bringing down positive symptoms. You also have to ask yourself, how much of negative symptoms does this patient have? How much of affective symptoms? How much of aggressive symptoms? How much of cognitive symptoms? Look at all those things and then plan your strategy. Then I think we are able to help these patients in a much, much better way. So with this basic understanding of how psychosis and those can present, let's kind of go to talk about a little bit basic aspects of various neurotransmitters which are linked with psychosis, so that we can go ahead and talk about various molecules further. So one of the questions which I put up here is a simple one. Which of the following transporters is not linked with dopamine is the question. Which of the following transporters is not linked with the dopamine? Tyrosine transporter, VMAT2 transporter, dopamine transporter, norepinephrine transporter. So which of these transporters is not linked with dopamine? What do you think is the answer? Can you choose one among the four? Is it tyrosine transporter? Is it VMAT transporter? Is it dopamine transporter? Is it norepinephrine transporter? Okay. This is an interesting question. I see about 12% of people telling dopamine transporter is not linked with dopamine transport. I mean, dopamine, which looks little obviously weird, but it's important for us to realize. If you see, 32% of them have said choice 1, and another 32% of them have said choice 4. Now, what is the answer? The reason I asked you this question is because, see, when we read basic sciences, right, it is very volatile. It runs away from our heads, right? We need to keep revising. So if we kind of remember in small capsules, it makes us feel good about the subject we are reading. So I'll make it easy for you, and I'll also tell you the answer for this. D is dopamine, right? D is dopamine. Dopamine is which alphabet, by the way? Alphabet number? 1, 2, 3, 4. A, B, C, D. D is alphabet number 4. So let's try to remember 4 things here. What you need to know is, when you're talking about dopamine, there are 4 transporters you should know. There are 4 transporters you should know. One is the tyrosine transporter, or the tyrosine pump, which brings in the tyrosine which is required for your dopamine. Okay. Now, next point you need to know is the other transporter, VMAT. The third one is the DAT, that is the dopamine transporter. And the fourth one is the norepinephrine transporter. So all the 4 which were given in the choices are transporters which are important for dopamine. Please remember, alphabet D, fourth alphabet. So 4 transporters are required. The tyrosine pump is required to bring in the tyrosine. The tyrosine hydroxylase is the rate limiting step, right? Which kind of converts it into DOPA, and then the DOPA decarboxylase ultimately converts it into the dopamine. Now, the VMAT is something which is extremely important in today's thing, because a lot of research is happening around VMAT. What is this VMAT? VMAT stands for vesicular monoamine transporter 2. Vesicular monoamine transporter 2. So as the name suggests, it takes the ready dopamine and puts it into the vesicle and stores the dopamine in the vesicle. So that work is done by the VMAT. The dopamine transporter basically is a reuptake of dopamine, and norepinephrine transporter. So some of you have answered norepinephrine, thinking, why will norepinephrine transporter be linked with dopamine? You need to understand, dopamine transporter works only on dopamine, but norepinephrine transporter works on norepinephrine as well as dopamine. So that's the point here. So it's good for us to know there are 4 transporters which can be linked with dopamine. I am sure if you listen to this, you will never forget what are the 4 transporters which are linked with dopamine. Like that, let me teach you one more 1, 2, 3, 4. What 1, 2, 3, 4 I want to teach you now? These are four enzymes which you should know, which are linked with dopamine. What are the four important enzymes we should know? One is the tyrosine hydroxylase, which I just told is the rate limiting step. Another one is the dopa decarboxylase, which is the next enzyme which is important in relation to dopamine synthesis. These two, MAO A and MAO B, is involved in the degradation of dopamine. The catechol O methyl transferase is another enzyme which is involved in the degradation of dopamine. So the third and fourth one in enzymes here are linked with the degradation. The choice 1 and 2 here are linked with the synthesis of dopamine. So totally four important sets of enzymes are linked with the dopamine. D alphabet is the fourth alphabet. So four enzymes: tyrosine hydroxylase, dopamine decarboxylase, MAO A and MAO B inhibitors, and of course you have the catechol O methyl transferase. So that's another interesting point for us to know. Shall we go with one more four now? No, 1, 2, 3, 4, which is linked. What are these four now? These are the most important things as a clinician. There are four important pathways which are linked with dopamine. What are the four important pathways? The mesolimbic pathway. Next one is the mesocortical pathway. The third one is the nigrostriatal pathway. And the fourth one is the tuberoinfundibular pathway. Tuberoinfundibular pathway. Let me highlight a point here for us to remember as clinicians. The mesolimbic pathway is the pathway which is linked with the positive symptoms of schizophrenia. Mesocortical pathway is the pathway which is linked with the negative symptoms of schizophrenia. Nigrostriatal pathway, nigrostriatal, many of you would have already heard about it, substantia nigra, Parkinson's disease. So it is linked with the extrapyramidal symptoms, right? EPS, adverse event, which happens with a lot of our antipsychotics, is linked with the nigrostriatal pathway of yours. Tuberoinfundibular pathway. Where is the tuberoinfundibular pathway linked with? A lot of patients with antipsychotic use, what happens to them, especially in women? One of the biggest challenges is amenorrhea, right? Amenorrhea, which happens. Amenorrhea is because of increase in prolactin levels. Patients can end up having galactorrhea. Let me give you an interesting point here. I remember this lady who was about 59 years old, who came and met me. Her husband was about 60 years and they were working in the husband was working in a public sector company. And as per policy in the public sector company, what was the policy is at age 60, when they retire, they would not be able to get specialist services of a psychiatrist or other specialists in that hospital. They had to pay and get it. Now, what happened was, this patient is a 59-year-old wife of this about to retire person who came and met me about 6 months before. And she had some depressive symptoms looking more like dysthymia. We started her on antidepressant and all. It was not responding well. At that time, amisulpiride was into the market and a lot of people were telling amisulpiride at small doses can be used in dysthymia patients. So I wanted to try and see whether it can help this patient. So I started this patient on just 50 mg of amisulpiride, and patient responded very well. Now, after about 1-2 months, right, the patient responded well, and the retirement of her spouse happened. So they stopped coming and meeting me because they had to pay some fee to the hospital if they had to take the services of a psychiatrist in that hospital as per the public sector company. They stopped coming, and about 6-7 months later, one day I was just parking the car there and I saw this lady who carried a big file, and she said, "Doctor, do you remember me? I came to meet you. You helped me with the medicine. Now I'm roaming around because they're suspecting cancer in me." I said, "Okay, I understand. What cancer and all?" She said, "No, they're thinking of breast cancer. So they are asking me to get multiple investigations. Everything is normal." That's when I looked at the file, the reason she was evaluated for cancer and being looked for malignancy was because she started developing galactorrhea. And the galactorrhea maybe would have got infected or some nodule would have formed. The problem here was I had started her an amisulpiride, which is known to cause hyperprolactinemia. And she had never followed up with me because of some logistic reasons of that hospital. Unfortunately, she ended up having galactorrhea and some breast nodule, which she was going through a lot of investigations and running around with the hospital and all the stress about it. When I met her, when I spoke to her, she had active secretions happening from the breast. That's when I said, Madam, I think one of the things could be is this medication which helped you from your depressive symptoms might be actually causing this problem. Can we do one thing? Can we try to stop this medicine and see whether your symptoms improve? If it improves, well and good. You don't even need to worry about your cancer and other issues because other investigations are normal. We stopped the medication. Of course, we did a prolactin level, which was very high, and we stopped the medication. The patient recovered beautifully from her secretions and other breast nodule, and those things came down. And best part of the story was with just an antidepressant, she was doing very much fine. So why am I stressing this point is because as clinicians, we might start the medication, but we might not follow up with them. And the bigger problem in our practice is the patients will shift from one doctor to another doctor in the same city, different city, right? So a lot of times our colleagues would have started and we might be seeing the side effects of it. So it's good idea for us to communicate among ourselves. Let's imagine there is a doctor A who has started a medication and I see the side effect of that in my patient when they have come to me because somebody would have told, no, go to this doctor is better. So when they come to, it's a good idea for us to communicate among our own colleagues and say, boss, you remember this patient, you started medication, I saw the side effect in this patient. So this also helps all of us to become on the same page and help ultimately the community of these patients who are actually suffering and who need the best help. So look for these things. That's when you can understand and remember. To summarize all these things, 1, 2, 3, 4, 4 transporters, 4 enzymes, 4 pathways, very useful. It will help you. This whole slide is basic neuroscience of dopamine all put together in simple way. Okay. Now, I think which is the next number after 4? 5, right? Now 5 will be very unhappy because you're talking too much about 4. So let me make 5 also happy. You need to understand there are 5 basic receptors of dopamine. Dopamine 1, dopamine 2, 3, 4, and 5. In this, basically, they say in neuroscience, there is this D1 family of receptors. D1 family of receptors is nothing but the D1 and the D5 receptors. Okay. The D2, D3, and D4 are considered as the D2 family of receptors. So D2, D3, D4 almost function similar. So it is considered as the D2 family of receptors. The D1 and D5 are together, which is called as the D1 family of receptors. So D1 family is a stimulant of the cyclic AMP, whereas D2, 3, 4 reduces the cyclic AMP. That's the basic difference which happens between the D1 family and the D2 family. Another interesting point I would like to highlight to you is this dopamine is modulated by serotonin. Yeah, serotonin is the other neurotransmitter, right? We did speak extensively about it in the depression segment. So you need to understand serotonin doesn't only work on mood, it kind of modulates, it kind of smoothens the functioning of the whole dopamine. Why is it important? Is because you need to understand when you're treating aggression and impulsivity, many times you would have seen in your clinical practice, when you add patients with SSRIs, especially fluoxetine and all, we have seen a lot of impulsive behaviors coming down. It is not just the serotonin pathway. Indirectly, they change the modulation of the dopamine system. Why do you think SSRIs might be playing a role in addiction problems? We do use it in many of the technological addictions and other things, right? We'll talk about this at a later session when you're talking about addiction issues. Now, I would like to just highlight to you a fact that serotonin also has a role indirectly to modulate the dopamine functioning. So that's an important point for us to know. Now, since we are talking about serotonin and dopamine, it is important for us to understand there is another important chemical which you cannot forget to talk about. And a few years back, when, of course, when we were doing a post-graduation, well, these were just one small paragraph here and there telling schizophrenia has some link with glutamate and those. Today, you will have huge chapters talking about glutamate and those. If you want to get Nobel Prize, I think this is the neurotransmitter you should focus at. If you want to get to work on research of the future, this is the neurotransmitter you should be looking at, because glutamate is a Pandora's box by itself. I think what we know now about glutamate could be just a tip of the iceberg. In fact, I think the whole psychopharmacology series can be done on glutamate for about 9-10 sessions easily, and still a lot might be left over to talk about glutamate. It looks like that. But I am trying to keep it very simple and easy for us to understand. What you need to know is, if you're talking about glutamate, basically glutamate is a stimulant kind of a substance, right? So what you need to know is glutamate is active, it works. So when the glial cell wants to keep it stored in a safe way without it getting to be released as a neurotransmitter, it converts it into glutamine and keeps it safely. The glial cells will say, it is the savings account. It says, please become glutamine, and it keeps the glutamine in the glial cells and saves them and keeps. Now, why is this important? Because you can have transporters. Now, what does this transporter do? Whenever the glutamate neurons require glutamate, it will take this glutamine and transport it. There are two important transporters which are there, which are linked with glutamate. What are the two important transporters which are linked with glutamate? One is the SNAT. What is SNAT standing for? Specific neutral amino acid transporter. Specific neutral amino acid transporter. Another one is called as alanine serine cysteine transporter, ASC, alanine serine cysteine transporter. So these are two important transporters which will bring out the glutamine which is in the glial cells back to the glutamate neurons, so that it can be put as a neurotransmitter out. There are, if you're talking about the vesicles, right, the glutamate will be stored in the vesicles. That is where there is the importance of another transporter which is coming here. And what is this transporter called as? It is called as vesicular glutamate transporter. As the name suggests, V-glut. Okay, vesicular glutamate transporter are the specific transporters which takes this glutamate and stores it in the vesicles. So once released, you have EAAT. What is that? EAAT. EAAT is the excitatory amino acid transporter. This excitatory amino acid transporter is the one which reuptakes the glutamate which is released. It is the one which reuptakes the glutamate which is released and brings down the action of glutamate. So that is the major breakdown pathway of glutamate. So glutamate is basically broken down by EAAT, excitatory amino acid transporter. When I say glutamate, you should remember something very interesting here. Glutamate, the word glue gives you a clue about glutamate. What is the clue you should remember about glutamate? It is very different from other neurotransmitters. What is the point which is the core important difference here? Glue. What is glue, by the way? Glue is a sticky substance, right? It sticks something together. Now, glutamate, for it to function very well, requires two co-transmitters. What are the co-transmitters it requires? Glycine and D-serine. If glycine and D-serine don't come and sit together, then glutamate will not be able to do its work. It needs right hand and left hand for it. It needs the right hand and left hand. Who are the two things? Glycine and D-serine. Easy to remember. Glutamate, glue, sticky substance. Two important things are required. Glycine and D-serine are required. Now, this will make sense to you when you're reading about newer drugs, innovative drugs which are used in schizophrenia, right? They'll be talking about D-serine, they'll be talking about amino acid modulation and those. Why? Because if you can improve these co-transmitters, that glutamate activity also might improve. So that is the reason these drugs are coming into the market. So don't forget about glutamate. Glutamate has two important co-transmitters, the glycine and D-serine. Why is this important again? You should remember, as I told you, D-serine these days is considered as a supplementation strategy to see whether they can reduce, especially the cognitive dysfunction and those. They're trying to see whether it can reduce it significantly. Glycine transporter inhibitors are some of the newer drugs which are coming up into the market. The glycine transporter inhibitors are the ones which are kind of coming up. And when you're talking about glycine transporter inhibitors, currently they're looking at glycine type type 1 and glycine type 2 transporters, which they are looking at. And these, you need to know, are basically working in the glycine T2 is basically working in the glycine neurons, whereas the glycine type 1 transporter is basically working in the glutamate neurons and the glial cells. So type 1 transporter is working mostly in the glial cells and the glutamate neurons, whereas glycine transporter 2 is basically working in the glycine neurons. So that's important for us to remember, because they might ask you in some of these exams where the examiner is very interested in all the basic neurosciences. They might check with you with all these aspects. So let me put up a question for us to see whether we'll see how many of you answer it correctly. What are the metabotropic receptors? What are metabotropic receptors? These are receptors linked to ion channel, voltage channel, G protein, or potassium channel. Or which one of these are called as metabotropic receptors? What do you think is the answer? Out of the four choices? Looks like a pretty easy question for most of you, because 64% to 65% of them seem to have answered it as choice 3, which is the G protein. So if it is linked with ion channel, it is called as ionotropic receptors. If it is linked with G protein, it is called as metabotropic receptors. It is called as metabotropic receptors, right? So metabotropic receptors are nothing but those which are linked with the G protein. Now, when you're talking about glutamate receptors which are linked with the G protein, there are three important groups you should know. 1, 2, 3. There are three important groups. The group 1 is mostly post-synaptic in nature, whereas group 2 and 3 are mostly pre-synaptic in nature. Understood? The group 1, which is actually post-synaptic in nature, is extremely important for us because it is linked with another type of glutamate receptors. Now, the glutamate receptors metabotropic type is linked with the G proteins. Now, there are three important types, 1, 2, and 3. In that, if you take the type 1, which is the most important one in the post-synaptic receptors, it is linked with another type of glutamate receptors. What is the another type of glutamate receptors which it is linked with? It is linked with ligand-gated ion channels. These ligand-gated ion channels are nothing but called as ionotropic receptors. So metabotropic means G protein, ionotropic means ion channels. Generally speaking, metabotropic will be slower in action. Ionotropic will be much more faster in action, okay? Because it is linked with the ion channels. That's a basic difference. Now, when you're talking about ligand-gated ion channel, which is linked with glutamate, there are three important ion-gated channels we need to understand. The Nmda receptors, the AMPA receptors, and the kainate receptors. Nmda receptors are nothing but N-methyl D-aspartate. AMPA stands for alpha amino 3-hydroxy 5-methyl 4-isoxazole propionic acid, and kainate is the third type of receptor. So this is an important point for us to know. Glutamate is a complex molecule. Now glutamate comes and acts. When glutamate comes and acts in the post-synaptic receptor, you have these metabotropic receptors which are linked with the G proteins. So in this, that group of class 1 group of receptors which are there, right? They are linked with ion-gated channel, which is also glutamate receptors, but they are linked to the ion channels next to it. This ion channel receptors, which are linked, ultimately produces actions which starts off immediately and quickly. So that is where you have the Nmda receptors, the AMPA receptors, and the kainate receptors, which you should know. Now, with this basic understanding, what you also should understand here is this AMPA and kainate receptors are typically fast and excitatory and is linked with the sodium channel. AMPA and kainate receptors are fast, they're excitatory, and are linked with the sodium channel. So what about the Nmda then? Nmda typically is linked with the calcium channel. Nmda is typically linked with the calcium channel, and there is it is mostly in the resting state. NMDA receptors in the resting state, the magnesium ions would block this calcium channels and keep it at resting phase. So, which is the ion which is blocking the calcium channel here? The magnesium ions are blocking, in which NMDA. NMDA is related to the calcium channel, whereas the AMPA and the kinase are linked to the sodium channel. So it's a good idea for you to remember these basic points so that when you go and read about it in your books next time, it looks easier for you to digest the whole content. Otherwise, it sometimes goes all over the head, right? And so we will be coming to NMDA when we talk about some substances of abuse and suicidal behaviors in later sessions and all. But it's important for us to understand. I told you the calcium channel, right? Now, calcium channel in resting phase will be blocked by which ion? I just told you, which is the ion? It is the magnesium ion which will be blocking them. So if the magnesium ion goes off, it becomes an open channel and calcium starts coming in and depolarizing the whole system. Now, an interesting point you need to remember is this calcium channel in the NMDA receptors has a PCP binding site. PCP, phencyclidine binding site is there. This phencyclidine binding site is not just the binding site for phencyclidine, but it is also the binding site for your ketamine. Ketamine is one which is a drug which is kind of being thought about lifesaver in a lot of suicidal patients and those, right? So it's an important drug and it works at this PCP binding site. We'll try to talk about ketamine in one of the future lectures where we'll try to devote some time for ketamine. But here you can at least remember this much points. Now, NMDA receptor is a complex receptor. For NMDA receptor to get activated, right? Like a lot of other receptors just need that neurotransmitter. If it comes and binds to it, it gets activated. But NMDA is like a little stubborn. It says, I cannot work like that. I need at least 3 people to come to me to activate me. NMDA says, I want at least 3 people. Okay. So what are the 3 things which should happen? Glutamate should come and bind to it. Otherwise, it will not work. Co-transmitters should come and bind to it. By the way, how many co-transmitters are there with linked to glutamate? I hope you remember, right? We just spoke a few minutes back. Glycine and D-serine. Not just that. We also, the NMDA to get activated, the magnesium plug which blocks the calcium channel should get removed. That will happen with the depolarization. So when glutamate binds, when co-transmitters bind, when the depolarization happens, the plug removal happens, that is when the NMDA receptor will be completely activated. So that is what is the complexity of glutamate. See, if you see from the time I'm starting to speak about glutamate, right, neuroscience doesn't look easy, but I think it's important for us to kind of understand the basic understanding of how some of these crucial points work. That's more than enough for us to kind of learn about these aspects in a much better way. Now, glutamate is one neurotransmitter which can get the whole brain on the go. It's called as the master switch. It can get the whole brain active. There are multiple pathways linked to glutamate. We can't go to all of these aspects, but let me just highlight to you. There are glutamate pathways starting from the cortex to various part of the cortex itself. There are direct pathways, there are indirect pathways. The corticostriatal pathway is there. You have the corticothalamic pathway. You have the cortico-brainstem pathways. Like that, you have the thalamocortical pathway and hippocampus-striatal pathway. Like that, there are multiple glutamate pathways. We have no time to go into each of these things, but let me highlight to you something very important, which should be known for us as a clinician, as a psychiatrist. We definitely need to know. We'll go to that aspect of it. Since we are talking about glutamate and NMDA receptors, it's good to know how can we connect this in a clinical way. The point for us to know is, many years back, it was very easy to explain. Patients will ask, or the family members will ask, why am I having delusions, or why am I hearing voices? We can say there's some chemicals in your brain, it has increased, so that is why it is happening. So what does the medicine do? I'll give you an antipsychotic, it will reduce those chemicals and you'll be fine. Now, it was as simple as explaining that. But definitely we know it is not as simple as how we put it across to our patients. It is much more complex, and it is just not about dopamine. Dopamine seems to be the end product of the problem, but the main problem is what? glutamate or the NMDA hypofunction, right? So nowadays, we know schizophrenia is thought to be happening because of various reasons. And one of the core important reasons is the NMDA receptor dysfunction or glutamate connectivity dysfunction, which happens. I try to keep it as simple as possible because I understand only simple things. I think I should share my simplicity with you. So I'll try to keep it as simple here. Let's take two simple pyramidal cells which could be there in the cortex, or two important cells which are there in the cortex, two pyramidal cells or two important cells. There will be interneuron. That is, interneuron is between two important pyramidal cells, right? So this interneuron mostly is going to secrete your GABA, right? So this is the GABA interneuron. This much I'm sure all of us understood. Now what you need to understand is when you take these GABA interneurons which are there is one specific type of GABA interneuron which has something called as calcium binding protein. What calcium binding protein does it have? It is paravalbumin positive calcium binding protein. So it's a particular type of protein which is calcium binding protein called as the paravalbumin. This particular GABA interneuron is the culprit in many patients with schizophrenia. So this interneuron is the culprit. So this dysfunctionality is the one which leads to problem. Because it becomes dysfunctional, there is disconnectivity. The pyramidal cells which are there cannot connect very well, or the one bunch of cells cannot connect with the another bunch of cells pretty well because of the dysfunctionality or the disconnectivity which happens with this GABA interneuron. So that is an important point for us to understand. It doesn't end there, right? Now the GABA production can be disturbed because of enzymes like the glutamic acid decarboxylase. GAD67 is an enzyme which has been noted to be reduced in some of these neurons. So what I'm trying to tell you here is, other than that, you can also, when this GABA functioning is disturbed, there is a upregulation of the GABA A receptors. The alpha 2 subunit gets upregulated. So why am I highlighting all these 3 points here? First of all, one is the paravalbumin calcium binding receptor positive interneurons can be dysfunctional. You can have problems in glutamic acid decarboxylase 67 specifically, which can be lesser. You can have upregulation of the alpha 2 subunit, which can happen. These are all some different theories which are put across to say why different reasons why schizophrenia can happen. Now, this also highlights the fact today, if you're reading textbooks and about schizophrenia, right, you'll read about a lot of genes, and those genes are linked to, some of them are linked to the paravalbumin, some of them are linked to the glutamic acid decarboxylase, some of them are linked to the GABA A receptors, like that. You need to understand these genetic components are linked basically to this slide ultimately. So the crucial point, at least as a postgraduate, for us to know is to remember the paravalbumin positive GABA interneurons are one of the basic areas of disconnectivity which can lead to various problems. You can have different kinds of genetic issues. Some of the genes which contribute for schizophrenia are dysbinding, dystrobrevin binding protein. Like that, there are many others. Like you have the disrupted gene in schizophrenia. You have the neuroregulin. Like that, we can talk about different genes. That's a different topic. Let me leave it here as of now. But what you need to know is these genetics of schizophrenia basically says the circuit gets biased in these patients. The patients are in a particular vulnerable state. This biased circuit, when it reaches the right time, or rather the wrong time, the patients end up developing schizophrenia. So that is where you should know two important points: epigenetics and epistasis. Epigenetics and epistasis are two important components you should be always looking at, which can lead to schizophrenia as such. So what is epigenetics and epistasis, by the way? What is epigenetics and epistasis? Now you need to know these genes, right, can contribute in different ways in genetic contribution. Now, patients mostly are vulnerable to the condition, not necessarily going to develop this condition. Now, let me give a very simple example of one of the real life examples of one of my patients we saw. One of my patients had full-fledged schizophrenia, and she had a son and a daughter. They both of them were very concerned about their own mental health, and they were reaching adolescent age, and they had a separate session, and they wanted to come and meet me. And their question was to ask that, um, Doc, we want to know, would we end up developing schizophrenia when we become of similar age like our mother? That's the question they asked. Now, what do you answer them? Uh, a very easy answer to make them feel very good is say, no, don't worry, you might not develop it. But again, these are well-read people. They have access to internet. They wanted to know what is actually happening. So we had to talk to them about what is the risk of general population, what is the risk in different populations, twins, monozygotic twins, and those. I had to give different explanations. And I also had to tell them about how epigenetics and epistasis can play a role. Now, epigenetics is basically how some particular genes can get silenced or activated, and epistasis is how different genes can modulate based on the presence of other mutations and those. Basically, there is an orchestra of genetics which happens, right? And you need to understand the orchestra is going to constantly keep changing. If there is a child sexual abuse history, some genes can get off and get on. If there is use of weed, some genes can get off and some genes can get on. Like that, lifestyle, past experiences, other psychiatric conditions, parenting, and the kind of lifestyle experiences they have as in the growing years, all of this can play a role. So you need to give various ideas and tell them some things which is better avoided. Now, this guy, why I'm telling this is because the girl and the boy are monozygotic twins, and dizygotic twins. And what happened was the girl went on to do studies and stayed back in India with the family. The boy went ahead to study in US. Now, when he was in US, he was studying in his campus. Obviously, weed use was pretty rampant, and he got into regular weed usage, and he started having florid psychotic symptoms. And I'm not telling it's the weed which causes it, but with a family history of strong schizophrenia running around in his family, he was already vulnerable. He was it is quite expected that if he's getting into early age weed use, he's getting into trouble. So if you look at all these things, that's when you can highlight these points to your patients and explain to them why they need to be considering to deal with the specific conditions and how you need to address. Now, I think glutamate is so interesting to keep talking about. So I will leave it here. But before I leave here, I would just like to highlight one important point in relation to glutamate. Then we'll move on to talk about various antipsychotics which plays a role in these glutamate and those things. So and dopamine connections. So glutamate, if you're looking at, I told you the basic problem or a hypothesis is the disconnection, right? One glutamate neuron to the other glutamate neuron, there is disconnectivity, which is the culprit. Now, because of this disconnectivity, three major things happen. One is there is glutamate toxicity. And in your biochemistry, you would have read glutamate toxicity leads to neurotoxicity and neuronal cell death, right? So glutamate toxicity is not a good thing. So when glutamate neurons get overstimulated, because GABA neurons are inhibitory. Now, when these inhibitory neurons are washed off, there is overstimulation, which can lead to glutamate toxicity. So that is one of the reasons why schizophrenia worsens over a period of time with every episode. Second important point you need to understand is glutamate goes and stimulates the mesolimbic areas and works on the mesocortical areas. Now, you need to understand it works by two different ways, direct pathway and the indirect pathway. When it works directly, it stimulates and it leads to more dopamine release and leads to the positive symptoms in the mesolimbic area. But in the mesocortical area, it indirectly stimulates, so goes and ends in the GABA neuron, and the GABA neuron ultimately works on the dopamine receptor. So thereby, in mesocortical area, it causes hypofunctioning. So if you look at glutamate, same glutamate in the limbic area will lead to hyperfunctioning of dopamine. In the mesocortical area, it will lead to hypofunctioning of the dopamine. Hyper in limbic area, hypofunctioning in the cortical area, same glutamate. How? Direct pathway, indirect pathway. Direct pathway, it stimulates the dopamine. Indirect pathway, it kind of leads to the hyperfunctioning of the dopamine. So this complexity explains the positive symptoms and negative symptoms which are related to schizophrenia, right? Now, when you're talking about basically antipsychotics, we know antipsychotics work on dopamine receptors and serotonin receptors, right? But it doesn't work only on dopamine receptors and serotonin receptors. It seems to work on many other receptors like histamine, cholinergic receptors, norepinephrine receptors. It also works on various transporters, the serotonin transporters and the norepinephrine transporters. So antipsychotics don't just work on dopamine, don't just work on serotonin. They seem to work on multiple other receptors. So that is one of the reasons you end up having a lot of side effects and of course effects too. Conventional or typical antipsychotics are those which blocks basically the D2 receptors, dopamine receptors or the D2 receptors. Whereas what is atypical? Atypical is something which is going to basically block the dopamine as well as the serotonin receptors, the 5-HT2A receptors in specific. So that is the basic understanding what we need to know. Now, to kind of understand it further and even clinically kind of make some sense, let me highlight to you a few interesting points. They always say if a patient wants to have response, he should also have some side effects. Now, this is a very crude way of putting across. I remember many years back when we were in the practice, right? Like when we were learning, at that time, a lot of typical psychotics are used. We used to see extrapyramidal symptoms very commonly. So the dosage used to be increased till the level where the patient starts developing a little bit of extrapyramidal. When extrapyramidal symptoms are seen, we used to assume, okay, 80% plus dopamine receptors are already blocked. So it was an assumption that you require at least 80% of receptors of dopamine to be blocked so that you get some antipsychotic effect. Understood? If you block more than that, you end up having side effects like hyperprolactinemia, extrapyramidal symptoms, neurolepsis. Basically, what is neurolepsis? Neurolepsis is basically completely withdrawn, negative symptoms, blunt effect, all those things, right? So which can happen when more than 80% blockade happens. Now that is what is typically believed to happen. And the pathways, I did speak about it earlier, so it's good to know. Hyperprolactinemia is linked with the tuberoinfundibular, extrapyramidal is linked with the nigrostriatal, and the neurolepsis is basically linked with the nucleus accumbens area. Now, what is important here is, what do the atypical drugs do? The atypical drugs don't work like this. The atypical drugs work in a different way. How do they go and block, and what do they do? If you see, atypical drugs basically block 80+% of dopamine receptors in the mesolimbic area. And we know mesolimbic area is what is mostly linked with the positive symptoms of schizophrenia. So it brings down the positive symptoms. But it has a much lesser blockade of the mesocortical area, nigrostriatal area, and tuberoinfundibular area. So what does the atypical antipsychotic block do? It basically blocks much lesser receptors in the nigrostriatal and the tuberoinfundibular area. So once nigrostriatal area is lesser blocked, less EPS, tuberoinfundibular area lesser block, less hyperprolactinemia. When mesocortical areas are lesser blocked, what happens is it seems to have its own effect of procognition, and atypical antipsychotics relatively have a little better response to negative symptoms, right? Especially clozapine and to some extent amisulpiride are some of those drugs which are spoken to have specific effect on negative symptoms. So that's basically because of a little lesser blockade of the dopamine receptors which happens. Now, you need to understand this is the basic difference which brings in. Now, atypical antipsychotic almost does what you really want. Because when you're giving antipsychotic, what is your aim? You want to block the dopamine receptors, mainly where? where the positive symptoms are happening. And where is the positive symptoms arising from? The mesolimbic area. So let's go and block that completely as best as it can. And atypical end up blocking 70% to 80% only, and not more than that many times. So that is the reason why atypical is supposed to be having lesser EPS than those. Now, people over conclude. People conclude and believe, okay, that means atypical is better, typical is bad. Is it true? Do you think it's true? We know typical also works well, typical also works well equally. Typical has neurotoxicity, atypical has what? Metabolic toxicity, right? It has a lot of metabolic toxicities and other problems which can happen. So that's something which you should know. To highlight about the atypical drug and how it works, let me kind of ask you this question. So let us see whether you're able to answer it properly. Which of the following drugs has more potent blockade of dopamine compared to 5-HT2A receptors? Compared to 5-HT2A receptors, which of the following ones have more potent dopamine blockade is the question. So what do you think is the answer? Is it clozapine, aripiprazole, lurasidone, risperidone? That's something which has been asked here. Blockade of dopamine is more with which one? Risperidone, lurasidone, aripiprazole, or clozapine? Okay, so I see majority of them put it across as risperidone. There are interesting points you need to understand. That is why I've asked this question. What you need to know is whenever you prescribe a medication, we have to ask ourselves, what is the basic action we are looking for, and what are the possible other actions this drug can have? Because when you give a drug to the patient, right, we cannot say what is the exact action or what is the exact blockade which can happen. Different patients are going to respond in different ways. So to highlight that point, let me kind of put across some interesting points here for us to remember so that it makes it easy. Now, I showed you across the 5-HT2A receptors now. Now, 5-HT2A receptors are specifically important, we need to understand. But what you need to know is when you're talking about atypical antipsychotics, there are two basic receptors we are looking at, the dopamine receptors and the 5-HT2A receptor blockade, which we are looking at. So some of the atypical antipsychotics block a lot more of dopamine, much lesser of 5-HT2A. Some of them block more of 5-HT2A and lesser of dopamine. On that, we have some drugs which also work very differently. Now, to highlight that point, let me give you a simple understanding. What you need to know is if you're looking at dopamine, there is something which can put a brake on dopamine. There is something which can accelerate the dopamine. Something which can put a brake on dopamine, something which can accelerate the dopamine. Now, what does it mean? The 5-HT2A receptors, when activated, will put a brake on the dopamine. Whereas 5-HT1A receptors accelerate dopamine functioning. Getting it? So brake is the 5-HT2A receptors, whereas 5-HT1A receptor is an accelerator. So if you use an atypical antipsychotic, what are you doing? You are doing 5-HT2A antagonism. You're doing 5-HT2A antagonism here. So you're trying to block these 5-HT2A receptors. So if you try to block, what are you doing? You're kind of getting it out of the brakes. So you're kind of getting disinhibited there. That's what happens, right? Whereas 5-HT1A receptor is important because it's an accelerator of dopamine. This is where you need to understand there are some antipsychotics which are partial agonists of that. And they have specific rule, a specific use in clinical practice. What do these antipsychotics do? If you see these examples, aripiprazole, brexpiprazole, cariprazine, clozapine, quetiapine, lurasidone, iloperidol, ziprasidone, these are all drugs which are useful. In this, if you read aripiprazole, quetiapine, lurasidone, aripiprazole, quetiapine, lurasidone are drugs which are very useful in patients with bipolar depression or resistant depression. In patients with bipolar depression or resistant depression, we do use these drugs very commonly, right? Mainly because of its ability to do 5-HT1A partial agonism. So because it partially is an agonist, it kind of improves the dopamine activity. And maybe that improves the drive in these patients. Maybe it improves the energy levels in these patients. Maybe it improves the working memory. Maybe it improves the concentration in these patients. So that's the importance of using a partial agonistic action in some of these patients. So that's important for you to know. And another interesting point, which you would have heard in the antidepressant section 2, is when you're talking about partial agonists, some of the important other partial agonists, especially antidepressant classes, vortioxetine, vilazodone, of course, the anxiolytic buspirone, they're all 5-HT1A partial agonists. So next time, whenever you're reading a molecule and you come across something which is 5-HT2A antagonist, you need to understand it stops the braking system of the dopamine. So dopamine starts overactivity. Whereas 5-HT1A partial agonist has some activating ability, so can be used with antidepressant properties or to kind of improve some activity levels. You can use 5-HT1A partial agonist. So that's an important point for us to kind of remember about these aspects. So like that, there are various other receptors which you should have an idea about, which is also useful clinically in exams and those. When you're talking about antipsychotics, there are antipsychotics which works on the 5-HT3 receptors. Now, when I'm talking about 5-HT3 receptors, these are serotonin 5-HT3 receptors, 3 alphabet C, right? You need to remember it is linked with the chemoreceptor trigger zone. Now, a lot of antiemetics, especially the ondansetron, which which is commonly used, right? They are all 5-HT3 antagonists. And 5-HT3 antagonism is known to be linked with antiemetic effect. But you also need to understand, in the GABA interneurons, there are 5-HT3 receptors. When you antagonize that, what happens? When you see, GABA is an inhibitory substance. Now, when you go and antagonize that through the 5-HT3 receptors, automatically you will increase the inhibitory ability will come down. So automatically you will have serotonin levels increase, norepinephrine levels increase, dopamine levels increase. So basically, if you see, some of the antidepressant effect of some of the antipsychotics could be because of that. Now, you remember of mirtazapine, right? Mirtazapine is an antidepressant. Vortioxetine is an antidepressant, which also has 5-HT3 blockade. So the antipsychotics which go ahead and block this, like one of the important drugs is clozapine. Clozapine is something which also can help reduction in negative symptoms. Now, how do you explain clozapine reducing negative symptoms? One of the potential theories of explaining it is through the 5-HT3. So don't forget the third alphabet, chemo trigger zone, C, and then clozapine, C. Negative symptoms can improve. Why? Because it can work on the GABA interneurons by antagonizing the 5-HT3 antagonism. It can produce some amount of activity in these patients. 5-HT6 receptor antagonism is supposed to be pro-cognitive, and again, drugs like clozapine, olanzapine, asinapine are some which are very useful and pro-cognitive in nature. 5-HT7, if you look at, is very important. A lot of work happening now, and newer molecules coming up with 5-HT7. You need to understand. I've underlined vortioxetine is because of its ability to be effective in patients with depression because of its antagonism of 5-HT7. Now, 5-HT7, easy to remember. Again, as a postgraduate, right, we want to remember points because we want to answer questions in a theory exam, or we want to kind of learn the subject very well. We want to do research. It's a good idea to remember these points. So 5-HT7, S7. So please remember, 5-HT7 is basically linked with the serotonin, right? Serotonin self-modulates itself through the 5-HT7 receptors. Serotonin self-modulates itself through the 5-HT7 receptors. So from the Raphe nucleus, if you see, the serotonin neuron will send signals to the prefrontal cortex. but one branch of it will automatically come back through the GABA interneuron and stimulate the serotonin. It has a self-modulatory mechanism. So serotonin, yes, self-modulation, yes, it is through the 5-HT7 receptor. So what will happen when there is a 5-HT7 blockade? So when there is a 5-HT7 blockade, what happens? The GABA neurons will not be activated. When the GABA neurons are not activated, GABA signal will not be there. GABA is inhibitory. When the inhibition is lost, it will become overactive. So serotonin will be improved and increased in the prefrontal cortex. So that is where you have your antidepressant action. So next time when you read about these blockades, I am hoping that you have a better understanding of what is actually happening. Now, let's go back a few years back when we were kids. We would have read about Goldilocks principle, right? The three bears, not too hot, not too cold, and those. Let me go ahead and talk what I'm trying to tell here about antipsychotics. When you're talking about antipsychotics, if you look at typical antipsychotics going and blocking the whole of the dopamine receptors, you need to understand partial uh, uh, partial blockade is what is typically seen in atypical antipsychotics. In atypical antipsychotics, partial blockade is seen. One of the best examples I can give you is you have drugs like aripiprazole, brexpiprazole, and cariprazine. These drugs, ABC, aripiprazole, brexpiprazole, and cariprazine, they all have a partial dopamine agonistic action. They have a partial dopamine agonistic action. Okay, so they kind of partially agonist of the dopamine. Now, what is important here for you to know is in some patients, they will stimulate the dopamine more. In some patients, they might stimulate the dopamine less. When they stimulate the dopamine more, that's where you can have nausea and vomiting, is what you need to understand. Or patients can have positive symptom worsening. Some patients, when we start them on aripiprazole, they become more agitated, more restless, more worsening of positive symptoms, extremely nausea and vomiting. So that can happen. Or the other side, you can also have patients where the antagonism is too high. So the blockade is too high, which can lead to extrapyramidal symptoms and akathisia, which can come in. That's important for us to remember how you can use the same drug to increase and decrease. Now, why I'm highlighting this point is because a good clinician, when he has given a medication and a patient comes for follow-up, you don't abruptly stop one molecule and start another molecule because they have a side effect. You also ask yourself, okay, the dosage which I'm giving, is it working for the patient or not? Are the symptoms reducing? Is there some unwarranted symptoms which are happening? Those are questions which I have to ask myself before I decide whether it should be given or not to be given. So you need to understand atypical antipsychotic prescription is not as easy as, okay, dopamine blockade, chapter closed. No, there are different receptor blockades and different actions which can happen. Now, one interesting point of atypical antipsychotic, which I would like to highlight to you here, is quetiapine, for example, is going to go and block the transporters, the serotonin transporters and the norepinephrine transporters. Now, by blocking the serotonin and the norepinephrine transporters, they increase the level of serotonin and norepinephrine. There you have your antidepressant action. You know, bipolar depression, one of the well-recommended drugs remains quetiapine. Now, this might explain why quetiapine could be a good choice. When you're talking about alpha-2 antagonism, you know antidepressant mirtazapine, right, which is known to have alpha-2 antagonism. But can you talk about some drugs which are antipsychotics? Quetiapine, clozapine, risperidone, aripiprazole. These are all drugs which do have some usage in depression patients, and we know it can have alpha-2 antagonism action like your mirtazapine and playing a role. We also need to understand that patients with atypical antipsychotics don't only block the dopamine receptor, they also block the 5-HT2A receptors, which is nothing but also produce the anti-manic effect, right? The aripiprazole and cariprazine are examples. Now, they are having 5-HT1A activity, which I mentioned to you, is also extremely important for you to know. Please remember, anxiolytic effect and sedative effect are very, very important for us to know. there are just few other important points I highlight to you before we wind up for the day, because it's a huge topic, but I'll highlight to you some very clinically relevant points. When you're talking about sedation, what you need to understand and neuroscience behind it is very simple. When you're talking about sedation, there are three important blockades you should remember. What are the three important blockades you should remember? M1 blockade, H1 blockade, alpha 1 blockade. So M1 blockade, H1 blockade, and alpha 1 blockade, if these three things are happening significantly, the antipsychotic is going to be pretty sedative in nature. So all of your sedative drugs, like your clozapine is one of the sedative drugs, olanzapine are sedative, quetiapine is sedative, they all actually work on M1, H1, alpha 1, which leads to the sedative effect you need to understand. So that's an important point which I would like to highlight here. Like that, you also need to understand one interesting point which I would like to specifically mention here. As a clinician, we always will see people who are elderly. And in elderly, we need to understand every fall matters. Every fall matters, especially in elderly patients. Whenever you prescribe an antipsychotic, you might have already heard about black box warning telling about sudden cardiac death, which can happen. So you should be careful about that. So you should not give very high dosage right away, slowly titrate up, and those that a lot of us might know. But one simple thing which we miss many times is every fall which matters. What am I trying to highlight to you here? Alpha 1 blockade. Alpha 1 blockade can be central alpha 1 blockade, peripheral alpha 1 blockade. Now, central alpha 1 blockade can lead to sedation. Of course, when patients are very sedated, they might be drowsy, they're going to the restroom in the night, half sleepy, dark room. These elderly patients slip and fall, and they have a hip fracture, they become bedridden many times, and then they develop pneumonia, bed sores, they are in the downhill course. So that's why every fall matters. When you start an antipsychotic, be careful whether the patient might develop alpha 1 blockade, which leads to hypotension. What is also important you need to understand is peripheral blockade can happen. Now, peripheral blockade can lead to orthostatic hypotension by itself, which are the important antipsychotics which can cause peripheral blockade. Clozapine, quetiapine, risperidone, iloperidone. Now, quetiapine and risperidone specifically, a lot of psychiatrists prescribe in elderly population because it's quite tried and tested, and a lot of elderly population, we know we can use it pretty safely. But both of them have a lot of alpha 1 blockade potential. If you don't ask these patients, they will never even report to you. If you don't ask their family members, are they steady enough to walk to the toilets by themselves? Have they had recent falls here and there? Have they slipped more frequently these days? When they try to get up, do they feel giddy? If you don't ask these questions, they will never ever tell you. When will you come to know about them? The patient's relative will come and say, sorry, madam, we couldn't bring him for follow-up. The reason is because he's become bedridden because he has had a hip fracture. How did the hip fracture happen? Because of a fall. What could be one of the reasons for the fall? Alpha 1 blockade, orthostatic hypotension. So look for it, try to see, change the molecule sometimes, increase the fluid intake, sometimes reduce the dosage of antihypertensives. Those are things which we need to look at and try to handle these kind of scenarios in a much better way. So looking for this will matter. Now, no discussion of antipsychotics will end, especially if we're talking about atypical, without talking about metabolic toxicity. It's very easy for us to say that atypical antipsychotics looks the best. And today, if you're going to sit in your chamber, you'll see all medical representatives coming and meeting you and talking only about typical antipsychotics. Nobody, you will only read typical in your books. You will hardly prescribe, you'll hardly see in prescriptions and those. Does it mean atypical is good and typical is bad? Actually, you need to understand, not necessarily true. By atypical, you can have a lot of other problems which can happen. Some of the biggest important culprits you need to understand for metabolic toxicity is clozapine, olanzapine, other than clozapine is one of the best antipsychotics, right? But it still is one of the most metabolic toxicity is what you need to understand. So olanzapine, one of the main reasons why a lot of psychiatrists might be avoiding as a first choice is not because of its ability to work, its ability to cause side effects, especially metabolic side effects. So be careful. Risperidone, quetiapine, again, common drugs. Ziprasidone and aripiprazole are drugs which are less toxic metabolically. So they are much better choices in people who are extremely obese and people who are already having very high BMI weight and those things. There you can consider that. Now, clozapine, olanzapine, risperidone, quetiapine, they all drugs, if you look at, along with mirtazapine, right, have something in common. That's why I've given it here. So it's important for you to know they have antagonism of 5-HT2C and H1 blockade, which happens. 5-HT2C and H1 blockade, which happens, which is one of the important things which is important for you to kind of know here to remember. Now, mirtazapine also blocks these two things, 5-HT2C and H1, that is histaminic receptors. Now, what studies have shown is if blockade of both the 5-HT2C and the H1 together happens, then the metabolic toxicity seems to be increasing very, very high. Now, mm, uh, this is something which I would like to highlight to you, which is important as good clinicians for us to look at in our clients and help them at the earliest possible. There is a recipe of problem which is getting cooked as we are treating our patients, especially with psychosis. One of the important ingredients of this negative recipe is the negative symptoms. Patients who have negative symptoms, they'll not have an active lifestyle. They'll be very withdrawn. They'll be kind of not able to follow simple exercises and other activities and those. So negative symptoms makes them have a sedentary lifestyle. And we all know that psychiatry patients on drugs or without drugs are more prone to have substance use disorders and conditions, especially nicotine use. More importantly, even in patients who are treated with antipsychotics, we know sometimes the antipsychotics can cause negative symptoms and dysphoria, which is self-medicated by using nicotine, right? So substance use disorders are way more commoner in this population. Third important recipe of this is the metabolic symptoms, which can happen because of the bad lifestyle and the drug-induced state. So what are we doing here? We are cooking a problem. We are cooking a problem of negative recipe for the patients. Patients have negative symptoms. They have substance use disorder problems. They are taking antipsychotics, but the antipsychotic is further causing its own problems in terms of weight gain and dyslipidemia. With this dangerous combination, what happens is it's important for you to know that they're all interlinked, each one leading to the other problem more and more. And if you don't identify this and intervene at the earliest, you miss the patient. You miss helping these patients and kind of supporting them and getting better. So it is always good to check BMI, weight, fasting blood sugar levels, triglyceride levels periodically, at least 3 months once, for us to kind of know what are the metabolic parameters which are going by, so that this recipe which is getting built in the patients can be stopped at some point of time, because there's a negative recipe with these ingredients. We don't want these negative recipes to be there. That's an important point for us to know. Now, I will highlight one last important point, and which will stump us always and make you possibly read about antipsychotics a lot more in days to come. Now, if you see this picture, who comes to your mind? Some South Indian, some actor? I guess you're able to guess. There's this superstar, right? Why am I putting it across in the end of the talk here? One of the reasons is, if you read all the antipsychotics, it'll be one side, one chapter. If you start reading about clozapine, it'll be something else. You don't know how clozapine works, but clozapine is considered as the gold standard ever, right? So out of all the antipsychotics, clozapine remains the gold standard, and it has its own action. It works very differently with patients, and they respond different. They have a different set of side effects. They decrease the seizure threshold. There are other antipsychotics also which decrease, but the amount of worry we have with clozapine is not something which is there with other things. Agranulocytosis, which is a serious concern, myocarditis, which is a serious concern with clozapine, is not that much with any other drug. Salivation, which is an important side effect with clozapine, is not that common side effect with this. And one important point which no other antipsychotic does is, you need to understand, clozapine seems to reduce the tardive dyskinesia to some extent, and it also seems to reduce the suicidal behaviors to some extent. So these things stump us always about antipsychotics. These things stump us about antipsychotics a lot. So these are all some interesting points which we need to know. Now, with this, I think I try to kind of tell you how various antipsychotics are very complex in their presentations, the kind of receptors they work. I've tried to highlight to you about this molecule on glutamate, which is extremely important. Now, antipsychotics itself, we could have discussed in many more areas. Now, I haven't touched upon some of the side effect aspects and those because of lack of time. What I'll be doing it is when I'm talking about some of the drug interactions and other areas, we'll be touching upon some of the important antipsychotics which and related side effects and those which we'll be talking about. With this, I think we'll come to an end. I'll just see whether if there is any questions asked or anything which we need to answer. As such, anybody has posted questions? Okay, so we'll be catching up next time to talk on anxiolytics. Now, each of this session, please remember, is a basic discussion on these topics. I'm just trying to increase the curiosity, and I'm also trying to see whether you are willing to kind of jump into this ocean of neuroscience and psychopharmacology and learn. Because if you get to learn some basic nuggets of life, right, we start moving on. That's the aim of this whole session. There is some question, I guess. So please throw light on genetic counseling about schizophrenia. I guess this will deviate to a different topic. So since you have asked this question, I can assure you one thing. In the second last session, we are trying to talk about specific populations and those. We'll try to have one case discussion on maybe how we go ahead talking about genetics and explaining some patients on not just schizophrenia, maybe just mental health. Some basic tenets we'll try to touch upon. I will ensure that it will be done at least in the 8th session for sure. Okay, thank you. Thank you very much. Have a great day. Be safe. Take care. Thank you. Thank you.